Thank you.
Hi, everybody. I think we have 1 minute, so we will wait to start on time.
I'm guessing that you could see the attendees, the co-hosts and participants.
Yes.
So you could see everybody's joining now.
Yes.
All right. I'll go back on mute.
Still 1 minute to 6:30, so we'll wait to get started. Okay, 6:30, so we'll go ahead and get started, everybody. Hi, everyone, and welcome to tonight's webinar on tracheostomy patient care during COVID. Tonight, we have a presentation from two of our head and neck specialist nurses, Izzy Aldred and Daniela Estefez, on humidification and filtration for tracheostomy patients. This will be followed by a discussion and question and answer session with Barry Ford, clinical specialist physiotherapist, on some of the clinical applications of HMEs and HMEFs, as well as patient selection for use. My name is Alana Kelly, and I'm the clinical manager for ATIS Medical UK and a speech therapist by background. Thank you so much for the questions that you've all submitted so far, quite a lot. After the presentation, we'll do our best to ask Barry as many questions as possible. We'll also be following the questions that come in the chat and adding these into the discussion. You can ask questions during the discussion using the Q&A function, which is at the bottom of your screen. Very quickly, just to get through some formalities, please be aware that by providing a virtual forum for this discussion, ATIS Medical is not providing medical advice. The answers provided are not guidelines or endorsement. We've engaged Barry for the session tonight, and he will be compensated for his time. The presentation and the panel discussion will be recorded with permission. And now that the formalities are over, I'm happy to hand over to our head and neck nurse team, Izzy and Daniela, to start the presentation.
Thanks, Alana, and thank you for joining us tonight. Here is our short presentation on humidification and filtration in tracheostomy patients during COVID-19. This is a brief overview of today's presentation and the topics that will be covered during it. We're going to start with normal physiology of the respiratory tract. Next slide, please. So first, a little brief overview of anatomy before we go into the physiology. Here you can see the entire trachea from the thyroid to the cricoid cartilage, all down to the bifurcation with the carina, the ridge that separates the left and right bronchi to each lung. They are further divided into smaller bronchi until you reach the bronchiole, which no longer contains any cartilage. It's only smooth muscle. And then in the end, you have the functional units of the lungs, the alveoli. So now you have an idea of the anatomy, we can go into the physiology. Next slide, please. So for optimal pulmonary function, humidification, breathing resistance, and filtration are essential. So during humidification, the conditioning of inspired air is mostly important for the airway mucosa, which needs a moist and warm environment. Throughout the trachea and bronchi, you have respiratory epithelium, which is a type of ciliated columnar epithelium found lining most of the respiratory tract as respiratory mucosa, where it serves to moisten and protect the airways. And the function of the epithelium is related to temperature and humidity. The optimal temperature is body temperature, so 37 degrees and 100% relative humidity. Below and above these optimal conditions, the mucosal function is impaired. The breathing resistance and work of breathing optimize the alveolar function and gas exchange. Resistance ensures a difference is in pressure between the alveoli and the outside, the transpulmonary pressure that causes the small airways to stay open. This will be harder to accomplish if there was to be a direct and open connection between the lungs and the outside world, such as an open stoma. Some resistance is thought to be good, both because of keeping the alveoli nice and open, allowing mucus out, and as a stronger effect of gas conditioning, as longer breath length is thought to occur. However, research in this field is not given conclusive results as yet. The upper airways, especially the nose, act as a filter through a combination of filtration mechanisms, increasing the effect of each other. One is an increase of surface area, another the manipulation of airflow, and we're going to discuss these mechanisms later in the presentation. Next slide, please. Something else to take into consideration in regards to pulmonary health is the amount of dead space. Dead space means the volume of air that does not really take place in the gas exchange. You can imagine that when you breathe in air, a certain amount stays in the nose, mouth, throat, trachea, and bronchi, and it does not reach the alveoli. It's known as anatomic dead space. If you look at the image on the left, it is the neck of the bottle. In an adult of about 70 kilograms, it is roughly 150 mils. It can be further divided in the intra and extrathoracic dead space, which greatly coincide with the dead space in the lower and upper respiratory systems, respectively. Dead space clearly changes when someone undergoes a tracheostomy, as they only have the intrathoracic dead space, and that is important when looking at things such as tracheostomy tubes and HMEs, especially in children, as the part of the tube that extends from the neck and the HME itself contribute to dead space. To put it simply, if we were to breathe through a snorkel, our dead space will increase. Next slide, please. We're now going to talk about respiratory physiology in tracheostomized patients. Humidification, breathing resistance, and filtration are affected when breathing through a tracheostomy. When thinking about normal breathing at room temperature, inspired air, which is conditioned by the upper airways, is 32 degrees with a 99% relative air humidity when reaching the level of a typical tracheostoma placement. Nasal breathing provides a degree of resistance which leads to an increased gas exchange, more oxygen inhaled, more carbon dioxide exhaled. Filtration mainly takes place in the upper airway, mostly the nose. However, when breathing through an open stoma, room temperature inspired air is not conditioned. The air is approximately 27 to 28 degrees and has a relative humidity of approximately 50%. Decreased breathing resistance leads to a reduced transpulmonary pressure, increasing the tendency for alveoli to collapse. Filtration is highly reduced since it mainly takes place in the upper airways. So in short, with the loss of upper airway functions, we have a loss of heating or cooling, depending on climate, humidification, filtration, reduced breathing resistance, as the nose accounts for 2/3, reduced anatomical dead space, but also, a good point, a patient can lose up to 1 litre of water a day breathing through an open stoma. Next slide, please. The airway mucosa has 3 layers: the cell layer, the aqueous layer, and the gel layer. Ciliated cells have hair-like organelles called cilia that actively move back and forth in strokes. They help transport the mucus, which contains dust and bacteria, etc., out towards the pharynx, after which it can enter the esophagus or be coughed out, and this process is called mucociliary clearance. Now, in healthy individuals, the temperature and humidity is such that the cilia function well, and indeed sweep everything up and out. However, if any of the layers mentioned are altered, the function suffers. As we know, in tracheostomized patients, unconditioned air is inspired. So cold and dry air irritate and eventually damage the mucosa in the trachea and the bronchi, especially the cilia. It slows them down and it damages them. Because of the irritation that is caused, more mucus is produced, and because of the coldness and dryness, the mucus is stiffer and more viscous. So there will be less transport of the mucus, and also dust and microorganisms in the mucus are swept out less. This is the reason why so many tracheostomized patients need suctioning and why many patients are prone to respiratory infections. Remember, as we said before, the optimal temperature is body temperature and 100% relative humidity, and below and above the optimal conditions, the mucosal function is impaired. Next slide, please. We can take a lot of examples from laryngectomized patients who also breathe through a neck stoma. And here we can see examples where humidification is not optimized, impacting on ciliated cell movement. We're going to watch a short video that will show tracheal cells with loss of cilia, attached ciliated cells without movement, and attached ciliated cells with coordinated movement. We will play the video again so you can just see the importance of the efficiency of mucociliary function and the movement of cilia. It is entirely possible for the function of cilia to be restored when the humidification is optimized, even when damage has occurred. So in summary, when humidification is significantly reduced, it results in a negative effect. And whilst we know we cannot fully replace the function of the nose and the impact of the upper airway, we are able to improve the pulmonary health of tracheostomized patients through the use of a heat and moisture exchanger. A HME provides humidification of inhaled air, resulting in cilia function being restored, and therefore improve pulmonary function via reduced mucus production and reduction of coughing and less pulmonary infections. Next slide, please. So as we just mentioned, a HME can partially compensate for the loss of conditioning of inhaled air by the upper airways, and studies have shown several clinical effects, both short-term and long-term. As well as humidification, the HME provides the benefits of filtration, protection, and containment. And we're going to discuss HMEs in more depth later in the presentation. Next slide, please. The importance of filtration mechanisms in the upper airway will now be discussed. So filtration can help protect from microorganisms, pathogens, bacteria, viruses, fungi, as well as particulate matter, such as smog, which is man-made, or naturally occurring, such as pollen. Particles smaller than 3 micron and larger than 0.5 micron are filtered by the nasal mucosa. And to put that into perspective, household dust is on average 10 microns. We mentioned we would discuss filtration mechanisms earlier in the presentation, and here we are. The upper airway acts as a filter through a combination of methods that increase the effect of each other. One is an increase of surface area, another the manipulation of airflow. Responsible for these things are mainly the following 2 things. The vibrissae, the little hairs in the nose, these help increase the surface area and in that way help capture the particles, and the turbinates, which are the ridges that protrude into the nasal cavity, which also increases surface area and directing the airflow. Air is guided through the entire nose by the turbinates, adding resistance, real surface area, and some artificial surface area through currents and eddies. Then there's the mucosa inside the nose that produces mucus and has cilia. Particles are captured in the mucus and transported with help of the cilia towards the pharynx, where everything is ingested. What should also be taken into account is what's deposited on the walls of the mouth, pharynx, and larynx. Next slide, please. Filtration efficiency of the upper airways is difficult to measure, especially in humans. So unfortunately, most studies have been done on animals. From research with smoking baboons, an accepted model for human comparison, it has shown that the deposition in the lungs was 4% when inhaling through the mouth, compared to 71% when inhaled through an endotracheal tube, bypassing the upper airways. So 18 times more deposition in the lungs. With nose breathing, the difference is expected to be even bigger. Next slide, please. So in summary, with normal breathing, filtration is performed by the upper airways, mostly the nose. When breathing through an open stoma, filtration is highly reduced since it no longer takes place in the upper airways. Therefore, patients are expected to have a much higher deposition of particles in the lower airways, and this will increase the risk of pulmonary complaints and respiratory infections. When breathing through a HME with a filter, it provides a logical barrier for gross airborne material. If you think a fly can't fly through a foam filter, a HME combined with an electrostatic filter, such as the Xtracare, has a filtration efficiency of greater than 99% for airborne particles, including bacteria and viruses. It has an effective filtration and humidification of inhaled air to protect the patient, and it has effective filtration of exhaled air to protect direct surroundings of the patient, including HCPs. A normal HME only filters about 70% of inhaled air. And to call a HME a filter, the HME needs to have a filter capacity of more than 95%. I'm now going to hand you over to Daniela, and she's going to continue the presentation.
Thanks, Izzy. So the next part of the presentation will be about the specific challenges and changes in medical practice and guidelines for patients and healthcare professionals during COVID-19. Coronavirus is a variant of SARS, which stands for Severe Acute Respiratory Syndrome, and actually 15% of common colds are coronavirus. The difference with COVID-19 is that even though it has a lower mortality rate, it is a lot more contagious, reason why it is so dangerous. So roughly 2 to 10% of people infected with COVID-19 will require mechanical ventilation. There is 50% mortality when patients with COVID-19 are admitted to ITU. So these viral particles are generally spread by droplets and aerosols. Coughing, talking, or sneezing will generate droplets and aerosols that travel at different speeds. The droplets usually fall to the ground while the aerosols can stay floating in the air, sometimes for up to 4 meters away from patients, and the virus can remain in these aerosols for at least 3 hours. So obviously this poses obvious risks to the tracheostomized patients as well as the healthcare professionals caring for them. The tracheostomized patient has an open and exposed airway. They're usually complicated patients to manage due to their respiratory issues. They are prone to atelectasis due to loss of airway resistance, and they often have comorbidities such as diabetes, obesity, and lung conditions, which have been significant when they become infected with COVID-19. Tracheostomized patients have a permanently open airway, and when infected with COVID-19, due to the aerosolization of tracheal secretions and the high viral load of these aerosols, they pose a high risk to everyone around them. And for these reasons, they are considered super spreaders. Most of the procedures involved in the management of the tracheostomized patient are aerosol generating procedures, which then puts the healthcare professionals at high risk when looking after these patients. There has been challenges and considerations for the protection of healthcare professionals looking after tracheostomized patients infected with COVID-19, such as whether performing surgical or percutaneous dilatation when performing the tracheotomy, ensuring staff has adequate PPE during the procedure and after when looking after these patients. In terms of post-tracheotomy care, ensuring the staff is educated in the risks of AGPs and how to limit them. These patients are often severely unwell. In terms of performing safe suctioning, ensuring HMEs with efficient filtration are used, and encouraging self-suction and self-stomach care if patients are able to do so. In outpatient clinics, there has been a deferral of all non-urgent visits. There's been use of telemedicine and telephone screenings and consultations, and also considerations with PPE and room cleaning requirements post-visits. For patients at home and in the community, these patients have been encouraged to shield They've been advised to protect their neck airway by using HMEs and HMEFs, as well as performing hygienic stomach care with clean and dirty areas and frequent hand washing. So based on these challenges and considerations, several national guidelines have been issued. ENT UK advises to use HME with viral filter at the time of tracheostomy insertion and to avoid using humidified oxygen in ICU and to use HMEs only. The NHS National Patient Safety Improvement Programme issued a multidisciplinary guidance document for safe tracheostomy care, published only a couple of weeks ago, in order to reduce the risk of infections of hospital staff during the COVID-19 crisis. Due to the high pressure on the healthcare system, the management of these patients would be carried out by staff without previous experience. There is extensive guidance in this document, and within it, there are recommendations to use the Kelly circuit, and the use of this circuit is considered a non-aerosol generating procedure. We will be discussing the Kelly circuit further ahead in this presentation. This guidance has been the reference for the ACPRC as well. There have been numerous international guidelines issued as well, with recommendations to use HMEs with viral filter once the patient is disconnected from mechanical ventilation instead of tracheostomy mask, and to use closed circuits for deep suctioning. So as a consequence of these recommendations mentioned, HMEs have started to be used a lot more recently for tracheostomized patients. Using HMEs 24/7 is common practice and gold standard for laryngectomized patients, but not so much for tracheostomized patients, especially in the community. We have been getting a lot of questions about them, so now we will talk specifically about some of the solutions available and how they are used in clinical practice. This change in practice has created new issues of their own, which we'll be discussing with Barry and Alana a bit later on. So one of these solutions is the Xtracare. The Freevent Xtracare combines a HME with an electrostatic filter that filters more than 99% of virus and bacteria. So it is an HMEF. It has very small dead space when compared to other in-circuit HMEFs currently used in ICUs. Humidification retention is excellent, even during oxygen therapy. It provides a bidirectional protection, so it provides protection for the patient during inspiration, providing filtration of the inhaled air, and also protection for everyone surrounding the patient, as it also filters the expired air. In terms of pressure drop, which represents breathing resistance, it is at a comfortable level for the patients that use it. So here we have a structural view of the Xtracare HME. It is designed for maximum filtration and minimum resistance, and as we have mentioned, it has a bidirectional electrostatic filter. And it has been tested with aerosols in the same size range as the aerosols carrying the coronavirus, and shown to be greater than 99% effective in these tests. So now I'm going to show you a video. In this video, we can see how the Freevent Xtracare can be used by itself, and lots of patients do so in the community and hospital settings. We can see how the oxygen adapter is applied, so over the top of the filter, and it clicks into place. The end, sorry, I'm ahead of myself. So the end of standard oxygen tubing can be cut, and it will adjust with a tight fit to the adapter. The adapter is for single use and should be replaced if it becomes dirty, contaminated, or shows any signs of damage. This way of applying the adapter is incorrect, as we've had some queries of clinicians that were applying it this way, and I will explain why in the next slide. The design of the O2 adapter is optimized for oxygen delivery. The oxygen enters the O2 adapter and is distributed all around the base of the Xtracare. So the vertical bar at the position of the inlet helps diverting the flow to the sides and around the device for a more even distribution. So in this image, where we can see here, the red represents 100% oxygen, and we can see it is evenly distributed all around the HMEF. In terms of its moisture retention, during oxygen therapy. That can be evidenced based on the device's moisture loss. So moisture loss is how the efficiency of passive humidifiers, or HMEs, is measured. The moisture loss value represents the difference in the amount of humidity on both sides of the HME when it is in situ. So the lower the moisture content of the expired air after the air passes through the HME, the better the HME is at retaining that moisture. So we want moisture loss to be low, which means that the HME is able to retain a good amount of moisture within it. So estimated moisture loss after the expired air goes through our nose is roughly 14 milligrams per liter. So the results of performance tests of the Xtracare with oxygen delivery have showed us that at 4 liters per minute of added oxygen, the moisture loss was 20.5 milligrams per liter, compared to 19.3 milligrams per liter without oxygen. So this is a very small change. So when the oxygen is administered 15 liters per minute, the moisture loss was 23.8 milligrams per liter, which is still a rather moderate decrease in humidification. So for comparison, when breathing through an open stoma without any added oxygen, the moisture loss was as high as 27 milligrams per liter during this test. So this capacity of the Xtracare of retaining humidification stays unchanged for a 24-hour period. So another HME option that contains droplets and aerosols when looking after tracheostomized patients is the Trachphone. This HME is commonly used by patients in the community, and as it provides great humidification. In this case, the oxygen connector bypasses the foam, so the oxygen delivery should stay below 3 to 4 liters per minute. It has an integrated suction port, which allows for suction without having to remove the HME, minimizing spread of droplets and aerosols. It can also be used for speech by pressing the HME. So we've got a small video that exemplifies how to apply the Trachphone by itself, pressing it for speech, and also using it for suction. And also how to apply the oxygen connector to the side. Okay. So the level of humidification required by patients will change depending on their clinical state, level of respiratory support required, and their degree of hydration. The way the National Tracheostomy Safety Project humidification ladder works is, if the current degree of humidification is not adequate enough, then the patient should be stepped up to the next level. Patients with tracheostomies are incredibly vulnerable to complications due to inadequate humidification, as we've discussed previously. And its importance in preventing tracheostomy-related complications cannot be emphasized enough. So this becomes even more important if the patient is unwell, dehydrated, or has copious or purulent secretions. So the COVID-19 update of the NTSB humidification ladder states that we should start with a dry circuit HME filter. So we have placed in this image the options we have just discussed that can be used in the first 3 steps of the ladder. So the Xtracare offers excellent protection with good humidification, and we can use it with a closed suction catheter to achieve maximum protection and containment of droplets and aerosols. The Trachphone offers excellent humidification as well, so can be used as well as the Xtracare in the first 3 steps of the humidification ladder. So just for reference, the second step would be to add mucolytics if necessary. The third step to add saline or hypertonic saline nebulizers. And then on the 4th step, if the patient is still struggling with secretions management, then we would consider changing it to a wet circuit. As previously mentioned, HMEs are widely used 24/7 in the laryngectomy population. The comparison between patient outcomes when using external humidification and using HMEs has been studied in the postoperative period after laryngectomy surgery. As previously mentioned, these patients' airways ends at tracheostoma level. So Merrill et al. In 2012 compared HME used immediately post-op compared to external humidifiers. And they concluded that there was better compliance, there was reduction in pulmonary and sleeping problems, and there were higher patients and nursing staff satisfaction. So this article on the right, published by Ebersol et al. Last week, compares HMEs with external humidifiers as well for post-laryngectomy, and it has concluded that HMEs are superior in reducing the incidence of mucus plugs in the immediate post-operative period. So going back to dead space, it is important to mention that the Freevent Xtracare is, to our knowledge, and in this present moment in time, the only HMEF purposely built for self-ventilating tracheostomized patients. In terms of dead space, as we can see in this graph, the Xtracare has less than 10% of dead space when compared to some of the inline HMEFs currently used in ICU and HDU. This is particularly important as the added dead space to a tracheostomized patient that probably has other pulmonary issues will significantly increase their work of breathing, hindering their recovery. So now I'll just briefly mention the Kelly circuit, and then I'll hand over to Alana and Barry to answer some questions about its clinical applicability. So the Kelly circuit was developed by the team of respiratory physiotherapists at Wellington Hospital in London, and it combines the Xtracare HMEF with a closed suction circuit. So this circuit combines a closed suction catheter, which is usually applied with the ventilator tubing in ICU, with an Xtracare HMEF for spontaneously breathing patients. So it provides protection for the patient, for the healthcare professional, and it enables non-aerosol generating suctioning. The Kelly circuit, as previously mentioned, has been recommended in some of the recent guidance documents, and specifically here by the National Tracheostomy Safety Project for pediatric tracheostomy care as well. So this next video is about an option on how to provide viral filtration for patients with tracheostomy tubes, but also to enable speech. And it is with the Micron HME. And the healthcare professionals that deal with laryngectomized patients will know what it is. And it is the HMEF commonly used by laryngectomized patients. So if the patient needs viral protection or aerosol containment when suctioning, the Kelly circuit can be applied this way by using an adapter. I'll show the video again. So there's picking up the adapter, attaching it to the side, and then applying the Micron, and then applying it to the tube. And then if the patient wishes to speak, they can press the side, they can press the HME. So one thing to bear in mind is that the dead space will increase when using the Micron with the adapter, and the tube cuff needs to be deflated. So in summary, tracheostomized patients are at higher risk for exposure to infection due to their exposed lower airway, and clinicians working with these patients are at higher risk for exposure to the aerosolized secretions due to the procedures involved in patient management. So these patients are also considered super spreaders and pose a risk to their communities and healthcare professionals. And due to these risks, many local, national, and international guidance documents have been issued to reduce contamination risk. So in summary, avoiding HGPs and containment of droplets and aerosolized secretions by using HMEFs and closed circuit suction systems are considered important in airway management of both COVID positive and COVID negative tracheostomy patients. So now I'll hand over back to Alana.
Thanks so much, Daniela and Izzy. What we'd like to do now is to help answer some of those questions that everyone has submitted about the clinical application and the use of HMEs within hospitals. So thank you, Barry. Just to give a quick introduction, I know I introduced you briefly to Barry earlier, but Barry Ford is a clinical specialist physiotherapist at the Wellington Hospital. He works in collaboration with the tracheostomy team, providing oversight for patients undergoing prolonged tracheostomy wean after severe neurological injury. Barry also has an interest in long-term ventilation and currently oversees the inpatient sleep and ventilation services. Thank you so much. We're very grateful for your time tonight and providing for us some of those clinical insights that we're getting lots of questions about. If you do have questions, just a reminder, you can put them into the Q&A function, which is at the bottom of the screen. We'll do our best to get all of them answered. Danielle and I will be moderating and sort of passing the questions back and forth. Any questions, like I said, we've received a lot already, but we'll try to interject some that you do add into the discussion as well. Okay, I'm going to go ahead and get started with our first one, Barry, if that's okay.
Sure.
So a lot of national and international guidance has been released recently, recommending using HMEs and HMEFs during COVID in the tracheostomy population. For some in clinical practice, this is a big change. And really the first question that we have, which we received a number of on this same topic, is how you decide when to use an HME.
Sure. Firstly, Alana and the team, thank you so much for having me today. I think it's a really interesting topic, and it's created a lot of debate, especially within our trust currently, about the changes which have come into place. In terms of the decision process with regards to when to use an HME, I suppose with regards to any humidification prescription, the first question as a team we have to ask ourselves is, what is the primary goal? Obviously in an acute setting, the primary goal most oftenly is to reduce the humidity deficit to the patient breathing through an artificial airway. However, for the patient that's perhaps at the end of their inpatient journey and maybe returning home with a long-term airway, often the decision for a humidification strategy is far more complex. It's very much around maintaining good pulmonary health, but it's also around function, around comfort. There's aspects around the aesthetics of the device, how it makes them feel, and very much how it fits into their day-to-day life and their roles once they discharge. But coming back to the HME specifically, our experience is very much with regards to weaning patients or downgrading patients from active optimal humidification down onto HMEs. And it's often so important because albeit active humidification provides optimal humidity, its practicality in the community is often difficult to transfer across. It also can create a burden on carers, families and the patient themselves. And there's also the financial aspects to consider. Whereas HMEs obviously offer certain benefits. In terms of HME specifically, what we would look for, there are clinical aspects, there are the environmental aspects, and there are very much the personal aspects. The clinical aspects would be, for a patient under the assessment, is ensuring that their secretion load has been kind of optimized, that they have a clear identified airway clearance technique, which is working for them, and they've had a degree of stability with that. We would also hope that from a pulmonary health perspective, they were clear of respiratory infection, and again, have demonstrated a period of stability. Because our feelings are it would be perhaps counterproductive to downgrade someone's humidity or humidification of the device if those aspects weren't optimized. We also tend to find that patients that are active or able to engage in some kind of physical activity or mobility are more likely to manage well with an HME. We definitely see the association between exercise activity and airway clearance, whereas perhaps high-risk patients will be those that weren't able to engage and weren't able to necessarily mobilize and move. The other kind of clinical factors would be very much around respiratory muscle weakness. So patients that present with severe respiratory muscle weakness or maybe quite severely impaired lung function would flag up as a concern for us. We would have concerns with regards to how they may manage the additional dead space or resistance from the HME. It's not to say we wouldn't use an HME, but we would be particularly interested about the profile of the HME and then the outcomes we would then use to evaluate its performance with that particular patient. In terms of the environmental factors, we would want to be assured that the patient could change the HME themselves, they could manage the HME, or there was a carer or a medical professional that could do that for them. they would need to be able to access the HMEs. A number of our patients move and transfer back internationally, and it's obviously critical that they can access the equipment they require. There are the financial, economical aspects of it. They need to be able to obviously fund it, or if it's on prescription, that needs to be feasible for them. And then lastly, from experience on the personal basis, we've found that success with HMEs very much starts with engagement with the individual. So it's so important. It's essential that the patient understands what the HME provides for them in terms of their pulmonary health, and that it would be an option that would work for them longer term, and also the family members that are on board. Otherwise, if we've missed this step, which we have done in the past, we'd often find that the HME perhaps wasn't being used, and it wasn't a kind of sustainable option going forwards. So really, there's some of the aspects we would assess a patient on with regards to establishing if it was the appropriate time and if they're the appropriate patient to use for an HME.
You've mentioned to me before as well a risk assessment. It sounds like some of that is encapsulated in the risk assessment that you use now within your hospital. Is there anything else that you do within that risk assessment that helps you to decide when to use an HME or when not to with patients?
Sure, so it's a great question. So initially when the guidelines were released, our trachea cohort went onto the closed suction systems, the Kelly circuits, as per guidelines. There was obviously a discussion between our physio team and our speech therapy teams, as our patients are highly dependent and have some of the complications and problems that I've mentioned. And we were concerned about safety and clinical effectiveness. We obviously understood that the Kelly circuit can mitigate risk to the clinicians, but there were some particular patients we were concerned as to how they would manage on the circuit. And with time, we have been able to collect some data to assess some of those outcomes. And from that, we formulated a risk assessment. So on the risk assessment, we risk stratify. So our COVID positive patients go onto the circuit and are managed on the circuit. Now, they have humidification outcomes which are set. If those outcomes are to change, and for example, their secretion load starts to become more stubborn or problematic, we take the initial conservative steps, which would be to offer mucolytics and nebulization. Again, if their outcomes continue to deteriorate, we would have a conversation with our medical team about escalation. So again, this may include such topics as moving patients into isolation rooms with heated humidification, or looking at early intubation. Then we have all of the other patient demographic. So these patients that have obviously not tested positive, we consider them as COVID suspected, because at any point they could have the virus, and from that they could also present asymptomatically. All of our patients would start on the Kelly circuit, albeit we have identified some certain subgroups that we wouldn't commence on the Kelly circuit initially. So the subgroups, as we referred to, would be patients that have a suboptimized secretion load, or perhaps those patients that are requiring a high intensity of chest physiotherapy or specific cough augmentation techniques, or have had a history of recurrent infection. Again, because we may feel that would be counterproductive and increasing the risk of the individual. Also patients that are on prolonged oxygen, and again, perhaps patients that are not mobile or able to exercise and engage in exercise would initially be upgraded to onto heated humidification, at which point their humidification outcomes would be monitored on a day-to-day basis. And when we felt those issues had been stabilized, if they'd stabilized, we would look to wean and downgrade as appropriate.
Thank you very much. You may have answered the next question, but yeah, when it comes to patient selection, we know that all patients won't be suitable. It's not a one-size-fits-all,
Sure.
sort of solution or scenario. But who do you see? Which patients are you seeing that are kind of ideally suited for that closed circuit, and which patients are ideally suited to using some sort of form of active humidification?
Sure. So I think we have a responsibility as clinicians to be accountable for this reasoning process, and I think we we have to balance clinical effectiveness of patients against mitigating risk is the first point, as per the purpose of the risk assessment. And again, kind of coming back to that answer, I can only talk from our experience, and we work on with a trachea cohort of patients that most of them have a disorder of consciousness. These patients are most likely hoist dependent. They can't participate exercise, and some of them do have recurrent problems with pulmonary health problems because of their long ventilatory weans. It tends to be those specific patients that we are more concerned about. And interestingly, what we have found from our experiences so far is when they have been placed onto the closed circuits and the HMEs, the clinical complications don't start initially from the outset in all cases. It tends to be anywhere from kind of 2 to 3 weeks down the line. And perhaps this tells us something a little bit about mucosal dysfunction in these patients. And often when we do see these problems, it tends to be not so much, we haven't seen tube blockage, it's been more around sputum retention. And the way in which we have defined that is sputum retention, which has resulted in increased work of breathing, or desaturation, which has been relieved with suction. So these are the kind of cohort of patients we're obviously more cautious with, and we feel an HME wouldn't necessarily be appropriate. But again, it's not to say that decision process wouldn't change in the future if we were able to optimize some of those factors which we've discussed. Patients that do tend, in our experience, to manage well in HMEs are patients that have, again, an identified airway clearance technique. They're free from infection. They're perhaps mobile, or if they're not mobile, they're able to engage in some form of physical exercise. And from experience, these patients tend to manage better with the HME product. And then there are patients that kind of fall in the middle. And again, we find this with regards to weaning from optimal humidification. There are some patients that benefit or require a period of heated humidification, perhaps nocturnally overnight, and then can suffice or manage with an HME during the day. Now, again, coming back to patient goals, that can be so crucial, because being on a heated humidifier obviously has benefits, but it comes with so many complications, and especially for the experience and the quality of experience of the individual. And having a period of time off of heated humidification during the daytime can facilitate and provide opportunity for function, for comfort, and all of those other aspects. So we tend to find other patients that just tend to fall in the middle, and that's why it's been so important to have a clear process in which we attempt to wean them down to a level of optimized humidity which works for them.
Are you also using HMEs or HMEFs without the use of the circuit as well? So just on the tracheostomy tube?
Sure. So we initially were using the closed circuit system, and we found that some patients were experiencing some discomfort, which was perhaps around the weight of the circuit or the application of the circuit. So in those cases, what we did was, again, we tried to risk mitigate, but still think about the aspects of care, and we were removing the closed circuits and going straight to an HME as the kind of next best solution. And we feel in this case, this has worked for these particular patients, and has provided a solution. Obviously, you know, one could then state the clear risk, which is then patients then still require open suction, so you're having to remove the HME to do so. So one solution to that would be something like the Trachphone, which Daniela Renizzi spoke about. Having something like the Trachphone in place obviously would then allow a clinician to suction, but while still containing the aerosol which has been generated.
Thank you so much, Barry. I'm going to hand over to Daniela for a couple more questions.
Sure. So next question, Barry. So what are your monitoring procedures for patients on HMEs or HMEFs? So do you keep them on a SATS probe? Do you check the filter when you do an inner cannula change? I'm assuming they're under constant supervision. So what's your procedure?
Sure. So I talk from the kind of the start of commencing an HME trial. So The first thing we do is we obviously meet with the nursing and care teams, and we talk about the intention of the HME trial and what it is we hope to achieve, and we assure that they're aware of the benefits and the ongoing kind of goal of the trial. Our patients are one-to-one special because they can't buzz or call for help. Albeit I can appreciate in some scenarios it may be that patients aren't one-to-one nursed. And I think if that was the case, then it would be looking at a risk assessment with staff in place and looking at the control procedures which would need to be in place to mitigate risk. As you said, having patients on SATS machines move closer to the nurse's station. It may well be their respiratory observations are completed on a more regular basis. In terms of your initial question, in terms of our monitoring factors, we have our bedside nurse complete quite a comprehensive document during their period of their shift. It would include factors such as suction frequency, the frequency of inner cannula change, as you've mentioned. It would also comment on the tenacity or the viscosity of the secretions, and also if there were any complications, as we mentioned about this episode we've witnessed with regards to sputum retention and desaturation associated. So these clinical outcomes are kind of collated, and then we use them to evaluate the performance of the HME prescription for the individual. We then make a decision on whether, on the time frame as to which we then repeat the ongoing assessment period with the HME to a point where we feel sufficiently happy that the prescription is safe and effective for the individual.
Thank you, Barry. So I think you've mentioned this, touched on this before, but do you think, we've been talking a lot about HMEs and HMEFs in hospital, do you think
Sure.
they also have a role for community patients?
Absolutely. I think every patient that has an artificial airway requires an individualized humidification assessment. Obviously, the key is very much around reducing humidity deficit for any patient with a long-term tube. And I imagine there are patients out in community. I'm aware there are patients out in community that aren't using HMEs. And obviously there are certain risks which this would suggest in terms of recurrent infection, patients also having the experience of problematic sputum, suboptimized airway clearance, which causes a great deal of discomfort and grief for patients long-term with long-term airways. I think an HME is an effective solution, but again, it has to be assessed formally and it has to be the right solution. It has to be personalised for the individual. And I don't see why that can't be completed in community. Once again, if the right risk assessment procedures are in place and the right considerations and accountability is there.
Thank you, that makes a lot of sense. I'll hand over to Alana for another few more questions.
Where I think we ran out of time. Just quickly to clarify as well, we had a question come in that says, what is an HME versus an HMEF? And an HMEF is an HME with a filter, so a viral filter. It's, again, what is in the closed circuit, and it provides that bidirectional protection, so protection for the clinician and protection for the patient, which is why we call it an HMEF. Another live question that came through is about how frequently HME should be changed. And Barry, if I could just ask you to address this just in terms of, the current sort of, current clinically, do you find that you're changing the HMEs more often in patients, or how frequently do you suggest this?
Again, I think it's very individualized and personal to the patient. And I can only talk from our experience in our cohort of patients, which I described earlier, we do find that we have to change them more regularly than perhaps on a 24-hour basis. We are changing them. It can vary between 4 to 6 to 8 hours, but again, it's very much dependent on the individual. And again, if we are finding that patients are having or requiring regular change of their HME because of problematic sputum, we might then problem solve by introducing an airway clearance session, which may be in the morning period or in the afternoon period, to try and facilitate that clearance effectively, to see if the patient then is able to go for a longer period of time without requiring that subsequent HME change. But again, if secretions are coming up and clearing with HMEs, we see that as a positive sign, because it's the mucosal pathway performing its function. We're more concerned generally if patients who are being downgraded start to not bring up sputum, especially if they're regular sputum producers, and if their secretion load starts to change, and that would flag up concerns.
In those patients who maybe you feel like aren't suited for using an HME or a closed circuit, do you go back to trialing an HME later on? Obviously, the guidelines suggest it right now. So, how do you sort of define when they would be successful to use an HME?
Sure, I think it's a really good question. I'd like to think, I think we work with patients that, and their long-term goal is often to liberate from ventilation, and then it's then to liberate from a tracheostomy. And as clinicians and for everyone watching, we're very aware of the benefits for achieving those goals. I've never perhaps before looked at humidification in that way. I've always looked at optimizing and kind of and providing safe, effective care. And that is still important, but I think my understanding has broadened more recently. And I think for patients that want to then transfer out of the unit and to get home, it's so much more complicated, as we said previously at the start of the presentation. And patients go home and we want to reduce the carer burden which is placed upon themselves and their families. So I would advocate for regular humidification assessment. And that's part of our Trachea ward round now, in terms of auditing that we are following our risk assessment. We'll also regularly coming back to that question, is there scope to wean this patient? If we are going to do it, which outcomes are we going to use, and how are we going to evaluate its performance? So the short answer to your question is absolutely, as and when there is opportunity to do so.
That leads into another question as well that we had was, do you see the COVID era as changing your thought around humidification, or has it changed your approach to using HMEs in this population in tracheostomized patients?
I think it has changed our thought process as a team, because I think initially we've obviously the primary focus has been around clinical effectiveness for our patients, and now we have to be accountable for mitigating risk. And HMEs are, for some patients, a practical solution to mitigating risk, or at least helping to reduce risk. And because of that function that they provide, it's essential that they are included in an assessment process for all of our patients. And I think going forwards, all of our patients will be considered for an HME. As we described, there will be those patients that aren't appropriate, and hopefully as time moves on, we'll start to see trends, and we'll be able to start to draw some conclusions as to which patients tend to benefit more from an HME and which require more support. But I do feel that all patients, should be considered for HMEs, and I think that is something, or perhaps the silver lining to come out of the COVID situation. It's encouraged us to think more broadly.
Absolutely. I think we've got time for one question before we get to our sort of final question. We had a question submitted about the role of using HMEs with patients who also use speaking valves.
Sure. This has been, again, a really interesting area of clinical debate amongst our trachea team at the moment. So from the perspective of a speaking valve, we understand it provides function, communication, it restores subglottic and intrinsic pressures, which is desirable for our patient group. But it doesn't have an independent humidity or humidification capacity. Now, I appreciate you could use a bib over the top of the speaking valve itself, albeit the concern would be with a bib as to its ability to provide sufficient absolute humidity within ambient air. And especially with our patients, I'm not convinced that a bib would suffice to provide them the level of humidity that they require. Obviously, the other option at the other end of the scale is an HME. So an HME does provide a humidifying benefit, albeit it doesn't restore subglottic pressure and intrinsic PEEP. So I think there is a role for both. And what we would advocate is that if a patient is having periods on the speaking valve, we would work towards trying to balance that against periods on an HME. Again, it could be that the HME is being used over the nighttime period when the speaking valve is off. But generally, definitely, we do feel that every patient should have an identified effective method of humidification, even if they are using a PMSV for that reason.
Thank you very much. We actually did have a question as well that I just wanted to address. Someone submitted and we're asking if there's any speaking valves for self-ventilating trachea patients that also have a viral filter. And I'm not aware of one. We have a product called the Xtracare, which is a speaking valve as well as an HME. You have it in open mode to use the HME function, and a closed mode, closed method, excuse me, for the speaking function. I'm not aware of any viral filter speaking valves. I'm not sure if you are, Barry.
I'm not, no.
No, okay. Thank you. I'll hand over to Daniela.
Okay, so Barry, what would you consider are the top 3 most important learnings that you think everyone should need to know in dealing with this patient population?
That's a big question. I can only try and speak on behalf of our team's experience. So the main question we have to ask ourselves is, are we doing the right thing, and are we doing it in the right way? And that's very difficult to do when there is change in practice and there isn't necessarily the clinical evidence to support everything we're doing within this scenario. So it's so important that we have risk assessment in place, and we are accountable for our clinical reasoning processes, which would demonstrate, and we would hope to demonstrate, that we are trying to balance mitigation of risk versus clinical effectiveness. So I think it's crucial that risk assessment in place to ensure that the wider team are all clear on what we are doing as a trust, and we're all working in the same way and are all on board with the same recommendations. The second factor to kind of complement that would be very much around using clear outcomes to evaluate our practice. Again, there have been some wider changes in how we manage tracheostomy care. And again, it's essential that the outcomes that we're using are sensitive to this change, and that we are evaluating how these outcomes to ensure that the new measures that are in place are clinically safe and mitigating risk. But more importantly, it's essential that with these outcomes that we're then sharing our outcomes with other teams and other clinicians. And again, as we said, in terms of moving towards new guidelines, we need to have an understanding and some conclusions based on the outcomes that we're having with these new practices in order to move and to develop our guidelines further. And the last factor, I think, would be very much around communication. Within our clinical teams, it's easy to assume that others and the wider team understand what it is that we're trying to achieve. But we have to also appreciate there's been so much change and so much information overload for individuals. And people are having to work within roles now where they're having to do things differently to how they used to do, perhaps doing things which perhaps contradicted what they believed in the way they practiced. So there's a huge education requirement. And the only way that we can achieve that is by having clear communication links with our colleagues and disseminating the information down to our colleagues or across teams to ensure that, again, everyone's comfortable and confident with the way in which we are practicing. Again, one example would be as simple as, recently there's been huge changes in the way that we prescribe humidification devices, but it's just making sure that after trachea wall rounds, that information is disseminated down to the nursing team and that they're happy with the intention behind what we're doing and why we're doing it. So they would be my top 3 recommendations.
And just to add on your last one, I think it would be really good that that communication is taken into account, especially on discharge from patients from hospital to the community as well, to make sure everyone is on the same page and we're all heading in the same direction. So thank you very much, Barry.
No problems. On that point, I completely agree, because if patients are undergoing a current wean or are on a new device or prescription, it's essential that those outcomes can be evaluated in the transitionary period and in the new discharge destination. And that responsibility and accountability falls on the clinical teams, the inpatient teams, to ensure that that happens.
Yeah.
The rehabilitation continues and they get the most effective treatment. So
Definitely.
that has just flown by timing wise. We're running actually a couple minutes over. We did have a lot of questions still coming through. So thank you very much to everybody. I think what we'll do is we will aim to respond individually over email to some of those questions that have come through. But a very big thank you to Barry, to Izzy, Daniela for the presentation, and to Barry for all those insights. Really fantastic information. Thank you so much. We will be back this time next week with an EU panel discussion, and we will follow up with an invite for that tomorrow. So thank you everybody so much for your time this evening, and have a great evening. Bye-bye.
Bye-bye.
Thank you.
Thank you.
Bye.
Bye.